I'm Charles Soparkar. At Plastic Eye Surgery Associates, we've had a robust Botox practice since the mid-1980s. Over the years, we've performed many tens of thousands of botulinum toxin treatments. And, like many of you, we sometimes see patients who respond variably to the injections, or even not at all. Diminished or variable response to these toxins among individuals, and in some groups, has been well documented in the literature. Even in the original Botox trials used for the FDA approval, as shown in the Botox package insert, people over the age of 65 years responded more poorly to the toxin, and we've wanted to try to understand why. I'm sure the answer is multifactorial, but we may have found one more part of the answer. As you know, all of the botulinum toxin subtypes are zinc-dependent metalloproteases. Without zinc as a cofactor, the toxin light chains are completely inactive. Interestingly, research has shown that if one stores freeze-dried toxin in the presence of added zinc, the recoverability of the toxin function significantly decreases. So when we inject botulinum toxins into the face, for example, the toxin binds to the peripheral nerve, is internalized, and a light chain separates, and in the case of botulinum toxin type A, binds the SNAP25 protein. But to be effective, the botulinum toxin must rely upon having picked up either intracellular or extracellular zinc. We began to wonder whether some people might be relatively or absolutely zinc deficient, and thus less able to activate the botulinum toxins injected for treatment. It turns out that assessing zinc status is not trivial. Blood and urine levels of zinc don't correlate well with levels found in various body tissues. Tissue biopsy is required. Although zinc is stored in the body, the storage is not robust. Current dietary trends in the United States seem likely to favor relative zinc deficiency. Recent studies have suggested two things. First, the RDA, or recommended daily allowance of zinc, was too low, and recommendations made under the new US-Canadian DRI, or dietary reference intake numbers, are considerably higher. So why would people be low in zinc? We are cutting down on red meats. You need to eat about a pound of beef a day to consume one of the best sources of zinc. What blocks zinc absorption? Alcohol, casein in milk and milk products, phosphates found in most soft drinks, supplementation with vitamin A, divalent cations such as copper, iron, magnesium, calcium supplements for bone loss, commonly used preservatives EDTA and E391. Poorly absorbed forms of zinc compete with better absorbed forms of zinc. Malabsorption syndromes of gastrointestinal disease, such as sprue, irritable bowel syndrome, liver disease, and laxatives and fiber supplementation. And finally, the phytates. What are phytates? Phytates are the principal plant storage form of phosphates, which may bind zinc and not allow its absorption. Sadly, many of the foods rich in zinc are also laden with phytates. Whole grain baked goods, whole wheat products, cereals, soy products, oats, legumes including peanuts, peas, beans, corn, and rice. Clearly, many people may be at risk for diminished zinc status, especially the elderly, who may be on fixed income and consuming less relatively expensive beef and oysters, while simultaneously taking fairly large amounts of fiber containing phytates. So we asked the simple question, what would happen if we loaded people with zinc just before their botulinum toxin injections? Our study included 44 patients, all with well-established, individualized botulinum toxin injection patterns. The average age of our participants was 65 years. 75% were women. At first, we specifically included blepharospasm patients who had hard-to-treat disease. These are the patients who receive in excess of 50 units of botulinum toxin per treatment and have been deemed untreatable by others. Later, we opened the study to reliably easy-to-treat blepharospasm patients, hemifacial spasm patients, and finally, 10 cosmetic patients receiving botulinum toxin for facial rhytids. 2 of the hard-to-treat blepharospasm patients were being treated with Myoblock. 3 of the cosmetic patients were being treated with Dysport. The remaining 39 patients were being treated with Botox. In a modified double-blinded crossover study, patients were given one of the following for 4 days before each treatment: a placebo of lactulose, zinc gluconate 10 milligrams, or zinc citrate 50 milligrams with 3,000 units of phytase. The phytase was added so that the supplements could be taken without worrying about phytate blockage of zinc absorption. Patients were asked to keep a daily log of self-perceived toxin effect, and we then scored the degree of effect as rated by the patients on a scale of -3 to 3, and duration of the effect was recorded as a ratio of the usual effect duration, apparently independent of type of patient, type of toxin studied, or order of the crossover treatments. Patients receiving 50 milligrams of zinc citrate along with phytase scored the effect of their treatments significantly higher. In fact, 3 patients with hard-to-treat blepharospasm had such an increased effect that they were unable to close their eyes and gave negative scores, which spuriously decreased the effect that we've shown here. Similarly, we were astonished to find a nearly 25% increase in toxin duration across the board. Although we find the results of this pilot study extremely exciting, and our patients are now clamoring for more of the higher dose phytase combined supplement for themselves and their friends, there are several important points worth emphasizing. We don't really know what made the difference in these patients, whether it was the zinc, the phytase, or the combination. We don't know that one organic zinc is better than another. All we can say is what worked in our study and what did not. Too much zinc and/or too much phytase may each create toxicities, so a short duration supplemental pulse right before botulinum toxin treatment seems a reasonable approach to increasing zinc levels for a very short time. If patients take one supplement one time and a different brand a different time, there may be variations in toxin effect which can be just as confusing as no supplementation at all. If we are injecting a patient with what is a suboptimal treatment pattern, adding zinc will not make the pattern more successful. Although clearly there is much we have yet to learn about using the botulinum toxins and maximizing their effects, we and our patients remain extremely excited about these early results.